I'm
gonna do a screenshot of you talk.
All right, we're all
You get
set whenever
screenshots?
you're ready.
All right, hi everyone. My name's Dr. Celine Saulnier, and I'm a clinical psychologist by training, and I specialize in diagnostic evaluations of individuals with autism from infancy and first risk signs all the way through adulthood. And to give you some background on myself, I spent the first probably 20 years of my career in academia, first at the Yale Child Studies Center, and then I relocated to Emory University School of Medicine and the Marcus Autism Center when Dr. Ami Klin was recruited from Yale down to Emory, and that was in 2011. And I spent 7 years at Marcus helping to transform that huge clinical center into a center of science. And I did a lot of administrative work there. I was the director of research operations. And, you know, fast forward 7 years, I was becoming quite far removed from the clinical work that I love so much. So I did a very significant career shift, and I left Marcus and Emory in 2018 and opened up my own company, which is called Neurodevelopmental Assessment and Consulting Services. So I split my time doing private practice diagnostic evaluations throughout the lifespan, and then consulting work where I've stayed in academia on grants, consulting on clinical trials. I'm an author on a measure called the Vineland Adaptive Behavior Scales, so I do a lot of consulting for the Vineland, and teaching and training throughout the country and the world. So that's my story. And what I wanted to do today about this discussion in diagnostic evaluations was present to you some slides that just give you an overview of how we conduct the diagnostic process and then go into discussion. And so with that, I'm going to share my screen, and I sent these slides to Jareen so that you all have copies of them. But Maya, no, you're here. Just now I threw in one additional slide, so that won't be in the handouts, and I'll leave that one up longer so if people wanted to take notes, but I can always get it to you. But many of you are familiar with the diagnostic criteria for autism in the DSM. That's our like holy Bible for the behavioral characteristics we have to evaluate and see if an individual meets when we're thinking about this diagnostic label. So there are two areas of impairments, one being social communication interaction impairments, and they're listed here that you would have to see in an individual currently or by history. And then these restricted repetitive patterns of behavior. And these would be your motor mannerisms like hand flapping, rocking, spinning, shaking things, to fixation on topics of interest, to perseverations or stickiness on certain objects or parts of objects, a real need for sameness, like adhering to routines, not liking transitions, and then sensory sensitivity issues, either hypo or hyper reactivity to sensory input. So that would be covering your ears to sounds, not liking certain textures, tags on clothes, seams in socks, and things like that. So also currently or by history. So a person with autism has to have both of those areas of impairment. And these impairments have to be present in early childhood. That doesn't mean they have to be diagnosed in early childhood, and we'll talk about that. But certainly they have to emerge in early childhood, and the symptoms need to cause clinically significant impairment across contexts in one's life. And then we have diagnostic differentials to make sure we're seeing autism symptoms and not developmental delays, intellectual disability, or things like that. So there are lots of diagnostic differentials. And the subtypes that previously were in the DSM-4 no longer stand. They're just all considered to be under this umbrella of autism spectrum disorder. And then when we're going through the diagnostic evaluation, we're not just assessing for symptoms of autism, we're assessing for a lot of other things that come hand in hand, like intellectual disability, like speech delays, communication delays, medical and genetic conditions, and things like that, ADHD. So we're going to say this is autism plus whatever of these that we see, or maybe none of those. And then we will assign a severity level based on the symptoms that we see. And basically these severity levels mean how much support does the individual require, whether in the school or the workplace or in life? And so level 1 would be requiring the least amount of support, and level 3 requiring the most support. So every 2 years, the Centers for Disease Control and Prevention do an epidemiological report on the statistics of autism and the autism prevalence in the United States. This just came out a couple of months ago, and the prevalence is now 1 in 54 individuals, usually school-age individuals, that's how it's assessed, in our country have autism. That's 1.85%. That's actually now quite common, when autism used to be considered a rare disorder. It's 4 times more likely to be seen in boys than girls. The average age of diagnosis in our country is about 4.5 to 5 years of age, despite the fact that we can reliably diagnose autism by 18 to 24 months. So the fact that we have that big of a gap between when parents are usually seeing symptoms and bringing their concerns to somebody, than when something's actually done about it. We need to get better at closing that gap. About a third of individuals with autism also have intellectual disability or cognitive impairment. However, the majority of people will have average to above average IQs. And sadly, in our country, not everyone's identified when they actually have concerns in their development. So 84% of 4-year-old children actually received an evaluation prior to the age of 3. We know autism is one of the most highly genetic disorders, and if 1 in 54 people in the general population have autism, 1 in 5 biological siblings has autism. That is really indicating that there's a strong genetic liability. And not only will 1 in 5 siblings have autism, but another 1 in 5 siblings will have shadow symptoms of autism, meaning they have some of those symptoms we just discussed in the DSM, but not enough to meet full criteria. But it might be enough to require intervention. And then another 1 in 10 will have non-autism developmental delays, like a speech delay or a cognitive delay. So about 50% of siblings are vulnerable. This is the slide that I didn't put in that I wanted to throw out there for discussion, is autism in females. Because it's so much more prevalent in males, the vast majority of research in the field has been done on males. So we really know very little about autism's presentation in girls and women. And what we're finding out is that we're missing a lot of women and girls. They're often misdiagnosed with some other disorder, or they're missed to diagnosis altogether. And this is because females in general tend to present with stronger social skills and reciprocity. And so when a female with autism is socially motivated and reciprocal and engaged in interaction, people think, oh, that's not autism. Autism's social withdrawn. So she can't possibly have autism. Also, girls they tend to be more in tune to monitoring or imitating others, so they can mimic what to do in a social situation, even if they don't truly understand that situation or how to navigate it. Restricted and repetitive behaviors could be qualitatively different in females. So one study actually showed that the fixations tended to be more people-animal related rather than object related, what you tend to see in males with autism. And then there's a lot of research coming out on this protective effect. Both genetically, there's a protective effect in females, meaning that when we see genetic hits or genetic mutations in girls, they tend to be bigger or larger, or the genes took a harder hit in order to see the same presentation in a girl versus a boy. And with this protective effect, they call this the camouflaging effect, that these girls are mimicking or fitting in, even though they're significantly impaired. So this is something I would love to discuss on how challenging it is for people like me to identify and then diagnose autism when the diagnostic criteria don't necessarily apply. So a diagnostic evaluation for autism is very comprehensive and usually not ideally done by one discipline, meaning I'm a psychologist. I always want to see a speech pathologist involved because it's a social communication disorder. So in my entire career, I've always worked alongside speech pathologists. Now that I'm in private practice, I have them on speed dial so that I can call them up. And then we certainly have behaviorists involved to assess behavior. We have psychiatrists, neurologists, medical physicians involved to evaluate any co-occurring medical conditions. And then we do a lot of testing. So we do testing for cognition first and foremost, because the cognitive profile is the baseline from which you are judging everything else. You want to know where is this person's level of functioning compared to their same aged peers. Like a 10-year-old, do they have cognitive functioning like other 10-year-olds? If they're impaired and functioning lower, say like at a 6 or 7-year-old mental age, then we do expect social delays, but only down to about 6 or 7 years. In autism, sometimes those social delays can be much more pronounced, even beyond developmental delays. And so we do this with a host of standardized IQ tests, cognitive tests, and we assess cognition. And what happens in the field, and many of you have probably heard these terms, people start saying, oh, it's high functioning autism, it's low functioning autism. Usually when people use that terminology, they're talking about cognition, not actual autism symptomatology. So high functioning autism, quote unquote, was just autism without cognitive impairment, and low functioning autism was considered to be autism with cognitive impairment. Well, these two types of autism can present very differently. When you have someone with cognitive impairment, they're more likely to have medical co-occurring conditions like seizures or genetic disorders. Whereas when you have someone with autism who has intact cognition and language, they might not be as at risk to the medical complications, but they are more at risk to psychiatric complications like anxiety, depression, and suicidality, because they have the cognitive ability to have awareness of their disability and how things aren't going quite right for them in the real world. And so I love this article because it really highlights this in saying that we shouldn't use this term high functioning, because it really does a disservice to individuals who have intact cognition and language who are struggling tremendously because of their social disability. And then another part of the diagnostic process is assessing what we call adaptive behavior, or real life practical skills. So if you think of cognition as one's capacity or repertoire of skills, think of adaptive behavior as how a person applies those skills to real life with complete independence. So it's not what a person can do or what they're capable of, it's what a person actually does without help, support, prompts, or reminders. And that's very hard for people with autism. For whatever reason, we're still trying to figure this out. People with autism can have a huge repertoire of amazing skills, language, cognition, lots of things, but applying those in a functional manner, like to say hello and interact with someone verbally, that's much more challenging. And then for the speech, language, and communication pathologists, they're the ones who assess really into everything from grammar to syntax to semantic and pragmatic language and meta-linguistic skills and theory of mind. Like, do you have the same thoughts and feelings and likes and dislikes as someone else? All of that comes under the realm of a speech pathologist. So that's a very critical component to the diagnostic evaluation. And then we want to assess the autism symptoms. And when we assess for autism symptomatology, there's a twofold process. We want to really do a thorough history of that individual's very early development with a parent or caregiver, because autism is a neurodevelopmental disorder, and we want to see what those symptoms look like early on. And then we need to do direct testing with the individual face-to-face, right? So we want to test their cognition, their speech and language, but also their social communication and interaction. We want to see and feel and experience all of these social communication skills in vivo. And then we want to also assess for those restricted and repetitive behaviors. However, these are not always of high frequency. So if I'm assessing a person with autism and I'm only with them for 2 or 3 hours, I might not see many, if any, of these restricted and repetitive behaviors, which again is why the history is so important, to get that collateral information from parents, caregivers, teachers, whomever works and lives with this individual. And then beyond the diagnostic evaluation, there are a host of other specialty evaluations that are often indicated for someone with autism, which would be motor assessments for occupational and physical therapy, academic assessments for learning disabilities, that would be achievement testing, then ADHD, executive functioning, memory, that would be neuropsychological assessments, and then medical evaluations, hearing tests, genetic tests, imaging, EEGs and MRIs, sleep and feeding assessments, and then psychiatric evaluations. So when I conduct what's called a standard autism evaluation, I'm not doing all of this. I'm making referrals for the other specialists to do those additional tests. And then if there's one take-home message I want you all to have, is that there is not one measure on this planet that diagnoses autism. Clinicians diagnose autism, sadly, in this day and age. It's all left to our clinical judgment. So that means you want the person who's placing that label upon an individual to have a lot of knowledge and expertise, not only of autism, but of all the common differentials and also of typical development. So if I'm focusing on infants and toddlers, then I better know what a typical infant and toddler looks like to know when development derails or goes awry so that I can actually say this is autism. So that's a heavy burden to put on the shoulders of the people doing the diagnoses, but it helps you understand how subjective this process can be, and that there is not one nice litmus test that says, yep, I tested, this is autism, and it's confirmed. So I could say it's autism, and then a person can go down the street to another center, and that center can say, no, it's not autism. And I'm sure this has happened to many, many people that you know. So with that, I'd love to go back to, so we can all see each other, and then just open this up to discussion. Yes, Maya.
So this is Maya. My question is, what do you call sticky attention? I've never heard of that before.
Okay, that's a great question. So sticky attention is over-focused attention. So in autism, you can see individuals get stuck on something, whether it's a topic, whether it's an object, whether it's anything internal that you can't see, it's in their mind, that they're just stuck. And so mom's going, Johnny, Johnny, teacher's going, Johnny, Johnny, and the person,
hey, I'm talking to you.
Yeah. It's not inattention, right? It's not that they can't pay attention. It's they're so focused on something they can't disengage from it to attend to something more social.
So I've never heard of that before. When did they come up with the term sticky? I always thought it was
You know, I have no idea who coined the term, but we use it all the time, and especially in research when we're trying to identify risk signs. Infants do it a lot.
I definitely had sticky attention growing up, and I still have sticky attention, but that's why you stretch people on the spectrum.
Yep. Another more technical terms, over-focused attention.
Yeah.
Question, you mentioned at the very end that the evaluation can be subjective, even with this battery of assessments that you have that sounds so comprehensive. I'm a psychologist as well, working with children and families for the Department of Behavioral Health. Oh, nice. And so I'm curious about how, you know, because we're seeing more and more young people come to our attention through at DBHDD. How do we discern then what a good, thorough, because what you presented sounds like great. That would give me high confidence if we had all those different evaluations from all those other different professionals. How does one go from there to get a different?
Oh, it happens all the time. So, and I'm guilty too, right? I've taken away autism diagnoses that others have given, and I've given autism diagnoses where others haven't. So what is best practices? Standards of best practice are very comprehensive. Like I said, you're going to do cognition, adaptive behavior, speech and language, and autism symptomatology at minimum, right? That's best practice. And you're going to collect from outside sources, not just do, you know, with the individual and the parent. You want the teacher, you want residential place, any information. And then what measures do you use? The gold standard assessment measures for autism are considered the ADOS, the Autism Diagnostic Observation Schedule, which is a direct observation testing in vivo with the person, and then a thorough history. And there's a semi-structured autism-specific history called the Autism Diagnostic Interview Revised, the ADIR, but it's so comprehensive, it takes 2 to 3 hours to conduct with a parent, that no insurance is going to reimburse that, and no clinician in the community has time to administer. So it's really used more in research. But I'll tell you, I'm now only clinical. When I do an evaluation on a teenager or above, an adult, I need to do an ADI because that's such a long history. For me to determine, to really know myself that I'm going to make a confident diagnosis, I want that autism specific history, so I'll give it. And then for adaptive behavior, a clinical interview for adaptive behavior is best practice, and that's the Vineland Adaptive Behavior Scales. Whereas the rating scales of adaptive behavior can give you inflated scores and not as accurate. So when I see a report that has done the measures, as well as the level of expertise of the clinician, those two things together are going to give me confidence, like, yeah, they did this. Also multidisciplinary teams. When you see the evaluation was conducted by a psychologist, a speech pathologist, and a physician, I mean, ideal. But not everyone has that luxury. Only academic centers usually, and medical centers, have the luxury of doing that. So when I don't see that, then I'm going to, you know, wonder if I want to do additional testing myself. And sadly, only 7% of community practitioners use the ADOS in their autism evaluations in our country. Yeah. And if you think of the Marcus Autism Center, where they see 5,000 to 6,000 patients a year, and I worked there for 7 years. My colleague Christy Hall did a study on the clinical diagnostic evaluations that came through her clinic in 2 years' time. It was something like 500 kids. Her clinic, doing standards of best practice evaluations, took away 40% of community-based autism diagnoses, took away. So meaning when they actually used a very comprehensive battery, the community standing diagnoses no longer stood. That's not to say that these individuals didn't need intervention. So thankfully they were getting intervention because of that label, but it wasn't autism.
Well, that was the next point I was going to go to, because if 40% of those were not really autism, and yet those young people entered care under the auspices of diagnosis of autism, then you know, and maybe that certainly has implications for their service delivery plan. I mean, so have they been laboring kind of under, in other words, not getting the most appropriate treatment?
Exactly. Not only are they not getting their appropriate treatment, all the missed diagnoses of autism are not getting appropriate treatment, right? Everyone who is missed. Maya, hold on one second, because I just want to add to this, that the CDC, when they, up until 2 months ago, we had huge disparities. And I don't know if any of you attended the disparities panel a couple of weeks ago as part of this conference. We have huge disparities in African-American, Hispanic children, rural areas, lower economic status. Now in 2020, the CDC findings said, actually, there's no more difference in African Americans compared to Caucasian individuals. We're ascertaining them at the same rate, but we're still missing Hispanic children and probably lower disadvantaged, lower SES. So I think even though we misdiagnose a whole bunch, we're missing probably just as much. So I don't think this changes the prevalence rates of autism at all. Yes, Maya.
So this is Maya, and I'm involved with the Autism Plan for Georgia. In regards to the people that are being missed or disparities, does this have anything to do with those that live in rural parts of Georgia? Is that part of it? And then lack of funding?
Yes, absolutely. So I think there's enough research out there that shows that lower socioeconomic status, which comes also in these very rural areas, and limited access to care impedes or gets in the way of getting an appropriate diagnosis. And, you know, even with telehealth, or even with, let's say there is one person that they can drive to get an evaluation, those areas still have really impoverished intervention options, right? So even if you do accurately diagnose, there's not the greatest treatment options in those areas either.
Yeah, and even with the interventions, Dr. Salmier, don't you have to have an official diagnosis to get intervention? See, it's a very catch-22 in those areas.
It certainly is, because it's not only that do you need a diagnostic label of autism to get appropriate intervention, but with Medicaid laws here in Georgia, to get ABA or applied behavior analysis services, your evaluation has to have had an ADOS, an adaptive behavior assessment. And I think they're taking the CARS, the Childhood Autism Rating Scale, or the ADOS. One of those two measures has to have been given in order for the insurance companies to reimburse the ABA.
That makes me very angry.
Yeah. Nathan, do you have a question?
Yeah, I know back in the like 70s and early 90s, I run an autism support group. I know a lot of autism in the adults in my age bracket are being caught later in life. How much has it been improved for catching it in the childhood now?
So we've definitely done extraordinarily better with ascertaining autism in young children, right? I would say about 15, 20 years ago, there was a movement for early detection, and we definitely saw that wave. Now, those babies are entering adulthood or in young adulthood and realizing that we didn't do anything about autism services in adults. So I think the parents are now advocating strongly in that regard. But you're talking about the ones that weren't even lucky enough to get ascertained early, and now they're adults and just getting diagnosed now. There was a study that just came out in the last month. It was not on formal diagnoses. I think it was on individuals with autism themselves as adults, self-reporting their diagnosis. Did this also come out with the CDC? I'm not quite sure. And showing a much higher prevalence rate than even the 1 in 54. So saying that when people perceive themselves as having the autism symptomatology and you actually try to ascertain that way, you see a lot more autism in adults. But that's not formal diagnostic labels. And so I think what has happened is we've broadened our diagnostic criteria immensely over the years. So when I started out in the field, autism, I mean, classic autism, was someone with cognitive impairment, minimally to nonverbal, and only a very small percentage were those individuals with autism who presented still as classic autism, you know, flapping, rocking back and forth, fixating on something, but had language and had intact cognition, right? That was a small minority. Now we've come completely opposite, and now the minimally to nonverbal, really cognitively impaired people with autism are the small piece of the pie, and people who have intact cognition and language are the majority. So as that's broadened, we are casting the net wider. People like yourselves and Maya, you are so exceptionally bright, right? And you have language, and you're probably going through the educational system and not getting flagged because academically you looked fine. And school systems will say, well, we're not going to put our money there because that person's not struggling academically. It wasn't a focus on social and adaptive and all that. So that's now we're increasing the awareness that you have to look bigger and more than just at academics, because these social vulnerabilities can be really lifelong and debilitating. Yep.
Actually, no, that's not true at all. So first of all, I did struggle academically, but number one, I didn't want to study anything. And I just kind of wanted to sit in my own little world when I was in school. I thought that the whole thing with homework made no sense to me. And then I did not mask as much. I displayed a lot of disruptive behaviors
Mm-hmm.
that later started to turn kids off. So I did go into special ed, and that was later on. But in terms of my autism diagnosis, it was harder to detect. People thought I had ADHD. They focused more on the hyperactivity. And as I mentioned in Jennifer's section, Dr. Staplewack's session yesterday, my mom had, and my dad brought me to a string of doctors, and she talked to our family physician one time, and he made fun of her when she told him, you know what, do you think she has autism? And he made fun of her, laughed at her.
Well, I think, and you're raising an important point, that we have to educate our clinicians as much as anybody, because this awareness that the spectrum has become so broad hasn't reached everybody. And I think there's also a lot of controversy there where some clinicians, I don't want to just say physicians, but clinicians in general will say, that's not how I learned autism. So, autism is this, and it's this impaired or whatever, and it can't be that. I've also seen the controversy within the autism field itself, where there's a split in parents of the very cognitively impaired, mentally to nonverbal individuals who cannot speak for themselves, right? And then the group of self-advocates who can speak very articulately about what is autism, what are my struggles, what is neurodiversity, how much people should be accepting of this, and not talk about things like a cure or eliminating autism symptomatology. That dichotomy has become so divisive in the field that I think the people who feel like they owned the old term autism, right, of classic, very impaired individuals, saying, okay, we feel this is qualitatively different. So if you want to go and talk about neurodiversity and how good autism is and all that kind of stuff, and we should be accepting and all that, take the label and let's call this something else, because this does require a cure. Like these parents will say, you see my child banging their head against the wall till they're bleeding. They're biting their skin off. They're strapped in a chair because otherwise they would hurt themselves or me. That they are begging for some change in their child's quality of life. So I think we do have to be respectful of how diverse the spectrum is, and maybe the fact that it's become far too broad, and we have to start talking about autisms and potentially relabeling some of them.
I have a question. I'm Susan. I work in a school system. I'm a special ed coordinator in South Georgia, and we're fortunate, even though we're rural, to have 2 centers, psychological centers in our town where people can be evaluated, or children can be evaluated. And my daughter has autism also. But we find a lot of times, not always, often we do get paperwork for teachers to complete when there's an evaluation in process, especially if the child already has special education services. But often we don't, and there's no input from the school. And I'm not talking about just with autism, I'm talking about other mental health concerns or diagnoses. But recently I've had several meetings, and the parent has produced paperwork, and the way the parent has described the child at home and the way that the evaluation reads, the report reads, is not at all how the child functions at school. And it's hard to know how to address that.
Absolutely. Well, you can see it both ways, right? So I'll give the example of the child who loves structure and routine, who is quite bright when it comes to learning facts. That individual is going to present much better in the school environment than they are at home when things are less predictable and more chaotic, and actually more social, right? And then on the flip side, you can also see when parents have structured, they've basically really modified everything in that child's life to meet the needs of the child in the home environment. And so they look better there than they do at school when those accommodations are not met. So you can see it both ways. So you're absolutely right. That's why you need the comprehensive bird's eye view of both, and getting input from everybody. It is so challenging, right? And look at how much of our teachers are doing in this day and age that I can't even imagine if they're homeschooling their own kids, homeschooling everyone else's kids, and then being asked to like complete all of this paperwork that can take hours. It's really challenging. And then elementary schools, it's easier because you have one teacher per kid. Once you get into the middle school and high school, who is the primary teacher? Who is going to complete all that paperwork on behalf of the child? Who knows them best? And that can be really hard to find as well. So yeah, I hear you there. And I think when you have a different presentation in different contexts, it doesn't necessarily mean that one's better than the other or one's right or wrong. Kids can present differently across contexts. You know, by diagnostic criteria, autism needs to be present across contexts, but it can still present differently across contexts.
Thank
I
you.
have a question. I'm sorry. Are interventions for adults with autism the same as interventions for children with autism?
So that's a great question too. So interventions to me are not as much age-based as they are level of functioning based. So you could see the same applied behavior analysis strategies used, reinforcement boards, token economies, positive reinforcement, contingencies, all that kind of stuff used across the lifespan that can be very, very effective. But then for some individuals, for whatever reason, they don't respond well to the very behavioral techniques and respond more to a blend of developmental behavioral approaches or social communication approaches. I would say that when we have specific types of interventions that apply are for infants and toddlers. For infants and toddlers, definitely it's this blend of behavioral developmental approaches they call natural developmental behavioral interventions, NDBIs, and they involve a very heavy focused parent coaching component because the parents are the primary source of social interaction for infants and toddlers. So if you don't train the parents to naturally bring out these, these engaging activities to keep them engaged, then, just having someone come in a few hours a week to do it in absence of the parent is not going to be effective. Yes, Maya.
So this is Maya again. One thing I'm curious about is people on the spectrum that have the physical violent behaviors where they hit their parents or they hit their siblings. What are the findings on that?
Oh, all right. So let me just first say that my area of expertise, Maya, is in evaluation and not treatment. And so I would want to defer to someone who has treatment in behavioral interventions. But I always go by this motto, which came from a speech pathologist, and I already told you they're my heroes. So Karen, welcome. Karen's a speech pathologist. and this one speech pathologist said behavior equals communication. So when you have a social disability like autism and someone can't communicate because that's the nature of their disability, whether the communication's verbal, facial expressions, gestures, or all of the above, and eye contact, they're going to communicate with their behavior. They're going to hit, scream, tantrum, spit, bite, do everything to communicate their needs and wants other than the more functional manner. So anytime I see that type of behavior, I think, what can't they communicate? And the thing is, behavioral intervention's only effective in exterminating that behavior, extinguishing the behavior, only if you teach a more functional replacement for the behavior simultaneously. And so what I've seen fail a lot of times is just treating the behavior and not teaching more functional communication. And that's why the speech pathologists are critical and need to be part of the process.
Oh, thanks for the shout out, Celine. That's so nice.
Do you want to add anything there?
No, you answered it perfectly. I mean, that's one of the first things they taught us was just how, like, for everyone, right? Our behaviors, how they are communicative, and you know, either wanting to make requests or avoid something and not having necessarily the right tools sometimes. I mean, even I revert back to some nonverbal behaviors when I'm not sure. But those are great questions. Yeah.
And I think with adults and even older kids, the longer they've used the maladaptive strategy, the harder it is to undo. And so it can be pretty challenging for families that have lived with these maladaptive behaviors for many, many years. And those are the debilitating symptoms that we do want to eradicate. Those are the things we want to cure, right? It's not the autism, it's the debilitating behaviors that come with autism. Other questions?
So how
I think
long-
along those lines, I'd love to also say, especially for the young toddlers and preschool age children who are learning to speak and communicate who can't, then when they learn alternative functional strategies like sign language, augmentative communication devices, in no way, shape, or form should those alternate means of communication be considered to hinder the development of spoken language. They enhance spoken language.
So you said that your expertise is in evaluating. So how long, and I know it does vary depending on how much information you have from, you know, the therapists and different clinicians and different doctors, but what's more or less like the average time it would take from you getting the information to actually getting the diagnosis, whether it be, you know, an autism diagnosis or developmental disability or any type of diagnosis?
Yeah, that's a great question. So I'm going to say my normal process, and then I'm going to tell you my COVID process because they're quite different. So, so when I do a diagnostic evaluation, let's say a family calls me yesterday and says, I need this as soon as possible. I could have it wrapped up within a couple days. So my general process is I'm going to bring the person in for the evaluation. I usually do it across 2 days. The first day, I test the individual directly. And that usually takes 2 to 3 hours to do cognitive and direct observation. 3 hours with school age adolescents and adults can take longer because then I'm going to do some psychiatric assessments with them too. I'm going to do a psychiatric interview, assess for anxiety and depression. I'm going to give them rating scales to fill out on themselves. So the length of that depends. You know, a 2-year-old is going to take an hour and a half. 2 hours. So then the second day, which could be the next day, I bring the parent in, and then I do the whole developmental history. I do the assessment of adaptive behavior. So collectively that can take 1 to 2 hours. But now I've scored up everything from the prior day, and I've already made my diagnostic formulation in my head. If needed, that first day, I've called the school, I've called the psychiatrist, I've called the whoever I need to, the therapist, to get collateral information. And so by the end of my history with the parents, I give them a break, go get a cup of coffee, whatever. I just kind of continue scoring everything. And then that same day, I provide the feedback. I don't keep them waiting at all. I just go right into the feedback and my diagnostic impressions, and then I write the report, which, because it's just me, I have the luxury of being able to pump those out quick. They'll have them within a week. So for my clients, they can have it all wrapped up within a week and already be contacting intervention providers to get everything done. COVID has thrown a wrench into all of that, right? Because how do you assess autism which is a social disability, remotely. And this is challenging to everybody. And I'm on too many discussion calls per week to even tell you how I spend my time, but it's well spent with hundreds of other clinicians worldwide trying to figure this out. Can we do an ADOS through a computer? Can we actually assess autism symptomatology remotely? Eye contact, do any of you know if I'm looking at you? Like I don't even know where to look at the computer to know who I'm looking at in the eye. So now talk about coming in. I've seen 2 clients in my clinic since restrictions have lifted. Thankfully, they were both teenagers with intact cognition and language that could wear a mask the entire time. I could wear a mask the entire time. They could hold a stylus and not touch my materials. They could point with the stylus. They understood everything I asked them to do. A 2-year-old, that all is going to go out the window. Not to mention with these 2 teenagers, interestingly, they both had facial expressions that they directed to me over the mask. So that helped in my diagnostic formulation. I still diagnosed the female with autism. And the reason I did, even though she had nice facial expressions, I could see her eyebrows going, I could see her gestures. When I talked to her via Skype, I could see the disability in her face much better when I saw her full face. The other teenager did not have autism. I could totally see his facial expressions. Had they not given me any facial expressions through the mask, that would have been harder for me to assess. And then my diagnostic judgment call would be impacted negatively by the fact that we both had masks on. Mm-hmm. With a 2-year-old, I'm probably going to frighten them with the mask. They're not going to leave their mask on. They're going to drool and spit and touch everything that I'm touching. So we're both putting each other at risk. So I don't know the answer yet how to safely conduct a diagnostic evaluation in person right now. Without like constantly cleaning everything. And maybe Karen can talk about what's happening at Marcus, where a bigger center has better abilities to put up plexiglass and all this kind of stuff.
We have 8 minutes left, Lynn.
The what?
According to Doreen, sorry to interrupt, we have 8 minutes left.
Oh, okay. But I just wanted to say, in the 2 assessments that I've done, they've both taken far longer because I've broken up so many at-home remote sessions. Then I see them in person, but now I need to schedule a feedback remotely, and that's an additional session that I usually don't do. So those evaluations have spanned 2 to 3 weeks, and I don't even like it. It's too long. It is too long for me. I can't imagine for the parent. Yes.
Oh, can you hear me?
Oh, Jill. Yep.
Hey. Oh,
go ahead, Karen.
Yeah, I mean, go ahead. I can.
Oh, well, I was going to say I work at a school with children 6 months to 6 years. And when I am sending someone to be evaluated from my initial parent conference, where I'm trying to meet the parent, not overwhelm the parent, and hopefully get as far as let's look into this. We're using DeKalb County. I'm right around the corner from you. We have not accomplished this in less than a year.
Oh my goodness.
Can you get up Wi-Fi?
Wow.
It's always a full school year.
Well, I should say I don't take insurance. So
well, that's why I'm saying this is because I have a few parents who can go that route, but most of the time we're using DeKalb County, and assuming that they're 3 years old already. But we're going through the local school system, the Coralwood Diagnostic Center, and I know the diagnosticians there well. They know me well. We've worked together for years, and yet we have yet to get this process to result in any sort of therapies, anything before the following school year has started.
That's the case in South Georgia where we are. The average wait time for the intake appointment at one of the centers is 3 to 6 months, and then usually a month between intake and the evaluation, and then usually 6 to 8 weeks before you get results. So even if you tell them it's urgent, you're looking at a 6 months
Wow.
minimum.
So this is Maya. That was pretty much about the wait time I had when I got my re-diagnosis as a woman with Asperger's syndrome, or which is now level 1 autism spectrum disorder. And that was done by Dr. Lee and Dr. Osley at Emory Autism. Back then, I can tell you a funny story. So my aunt wanted to know whether or not I had autism because she's very interested in research and busting her butt. And so when we got the packet in the mail, I tried to hide it from my aunt because I didn't want to get re-diagnosed with autism. It was embarrassing. I wanted to be normal, but getting back on topic, it took them about 5 months, 6 months before I was able to get in and do what you're talking about, Susan.
Yeah, and that's everywhere, right? And Karen, Marcus is still a pretty long wait list, except for infants and toddlers.
There we go. Yeah, it's everywhere, you know, these challenges with insurance. And, you know, as you know, I serve a lot of the bilingual children, Spanish speaking children and families. And so it's always even longer trying to accommodate them with interpreters or helping them. A lot of times Lisa's referring them to me, you know, to help them with some of just orient them to where they should be calling before the appointment. But yeah, at Marcus right now, pre-COVID, we had a pretty steady flow of getting toddlers seen within 2 months. They were trying to prioritize, you know, we have been focused a lot on this early detection, early intervention. And then now with COVID, it's been a real challenge. I can tell you, I'm still working remotely for the most part. They've been splitting, as you were mentioning, Celine, the 2-day thing. I think some of the psychologists are doing GIs electronically, like WebEx, through telehealth.
Interview, yeah.
And then like older children who they can find their way around, you know, with more precautions and maybe level of comfort on both ends. So it's been a slow process of ramping up. But I think you were on that call with the navigator from Dr. Weatherby. So I know that there's creative ways, right, to doing SORFs and trying to help with that. That's a tool. Is it a screening tool, I guess we call it? Or
And everybody is trying to develop very quickly these workarounds to do remote assessments where you can have the parent set up scenarios to interact with their child, to play with their child, to have them engaged in some social interaction for you to observe as a clinician remotely and gather as much data safely in that manner, definitely. Yeah. But we haven't figured out how to accurately assess cognition remotely. And it's just so critical, especially in language. Language, there are some options, but it's still not going to be a robust communication assessment, right? Like, we just need that information for the diagnostic differential. I'm saying I think in this day and age, we need to let all of us off the hook a little and say, it's okay to give a provisional diagnosis and say, I'm on the fence. Like, I did the best I could, and this is all I can do right now for safety is say, I think this kid has autism and push forward for services. We just need the people on the service provision end to accept a thinking outside the box diagnosis and say, okay, when COVID lifts and we're all safe, let's reevaluate more closely. But right now, this person needs intervention. Let's go with this provisional diagnosis, you know, and I'll be the first to say, sorry, I got it wrong, you know, but we're doing the best we can under very extreme circumstances.
Yeah, I think it's better if you get it wrong as opposed to missing it.
Wait, right. As opposed to wait and see. Yeah.
thank you, Celine. I just chatted in. These are such great discussions, and I just, as a provider, I know we're all trying to do the best for our kids and our families. So I appreciate hearing from. Sorry, I caught the tail end of it, but
That's okay.
hope we can continue these chats and ways that we can support these guys.
All right. And
Thank
thank you guys so much for attending.
Thank you.
Thank you.
Stay safe, everyone.
Hello.
How are you, Maya?
Good, Dr. Rubin.
Good.
This is a really great discussion.
Awesome.
Oh, good. I'm glad.
I have to
Yeah.
go. I've got patients
Somebody
to
that
see.
wants to be in.
See you, Dr. Rubin.
Bye, guys. Nice to work
Bye.
with
Have
you.
a
so
good
Look forward to
day.
seeing you again.
Thanks for joining us. Keep in
No,
touch.
thanks, Susan. Thanks, Jareen.
Let me know of
Thanks, everybody.
anyone coming up.
All right, bye.
Okay. Look
Bye,
out for
Jareen.
the
Bye.
evaluation. I know I had some repeaters. I see y'all's familiar faces, Sadell and Musu and
Yes.
Dr. Pearson. All of you.
All right.
Latanya, I've seen you, and Nathan, Joe, all of y'all, my favorites. Sticking to the
Really-
very end.
All right.
This was really good. I was glad that
Appreciate
we
y'all.
were able to come together and do these
I
discussions.
agree. I definitely agree.
I
So
want-
please,
I want more.
you want more? Okay, so we're gonna send out an evaluation. We would love the feedback.
Okay.
So we can see what we can do moving forward. At this
Excellent.
That would be great.
Thanks as always, Jareen.
You're very
Right.
welcome.
Everyone.
Bye.
Happy summer.
You
I'm
too.
gonna
Stay
see
safe.
y'all.
Until next year, autism community. Until next year,
Yep.
AIDS community.
Yes.
Be soon.
Water,
We can
and
get
then
your
the Jareen,
for us.
waterfall, waterfall.
Waterfall, waterfall.
Be well. Be adventurous.
Bye.
When you, Jareen, when you found that jazz with the ocean, I thought it was a waterfall. So I thought you were coming up with a waterfall thing.
Oh, no, it wasn't associated with that, but that's a good point.
Yeah, waterfall. I'm sorry, I don't want to say that over and over again.
You're fine. See you, Joe. See you, Nathan.
Y'all take care. All right, y'all be blessed. Take care.
Okay, you too. Take care.
This was a great, I think there was a really great team on the committee this year.
I agree.
Yeah.
And
I think everything went.
couldn't have been more proud of us together. So
Yeah. Thank you.
All right.
I couldn't do it without you guys, really.
thank you. All right. Well, have a great one.
All righty.
Bye.
Enjoy the
Thank
rest
you.
of your
Don't
day,
forget to put
everyone.
those,
Yes,
videos
I
in
will. Yes.
Dropbox, okay?
Oh.
Maya, it was really for her. I know you know. See ya.
All right. See you later.
Goodbye.
I close out of here.
I got you.
All right.